Hi, everybody. This is Dr. Sam Sunshine. Let me know if you can hear me. If you don't mind typing in the chat box if you can hear me okay, that would be great. Or if you're watching live, if you don't mind typing in your name and where you're from, that would be helpful. So today's topic is going to be on heart disease. And heart disease is, first of all, a very broad topic and also a very complex topic. And so people are probably wondering why, in the midst of a pandemic, we have social injustice, um, kids aren't going back to school. Why am I talking about heart disease? Well, heart disease is one of the topics that I've just been wanting to talk about for a while. We are getting into flu season. Thank you. Thank you, Sandy. There's been studies, a recent study came out last week that if you do get the flu, it does increase your risk for having a heart attack and being hospitalized for a heart attack. And that the flu vaccine doesn't seem to protect you from getting a heart attack if you develop or you get stricken with influenza. Hopefully, this will be a very mild flu season, as we have seen in the southern hemisphere continents like Australia. But time will tell. But heart disease is such a prevalent condition in our society. And it's important that people understand what they can do to mitigate the risk and try to prevent the risk. In the United States, we have very high levels of heart disease, primarily because we are sedentary, we tend to be overweight, we tend to eat processed food, and we seem to be under a lot of stress. So those are going to be things we're going to talk about. I'm going to primarily focus on coronary artery disease today. So there are various causes of heart disease. We're going to focus on coronary artery disease. And I'm going to talk a little bit about the coronary arteries and talk about some of the screening tests you can do and ways to, again, mitigate your risk. So first, I'm going to ask you, do you know how many beats or how many times our heart beats in a day? So if you can type in your answers there, it'd be interesting to see. But on average, our heart beats 70 times a minute. And there are 60 minutes in an hour and 24 hours in a day. That adds up to 100,800 beats per day. So that's pretty significant. You think of the volume of blood that our heart beats per day for our entire life, from the moment of conception, well, not conception, but in utero, our heart starts beating, and then until the day we die. It's just phenomenal. To me, it's just unbelievable that our heart is that industrious. It doesn't quit on us, However, it is the leading cause of death in the United States and worldwide in both men, women. It doesn't matter. It doesn't spare racial or ethnic populations, and the incidence is pretty staggering. I think the numbers are in about every 40 seconds somebody has a heart attack in the United States. And annually in the United States, there are roughly 855,000 heart attacks. About 805,000 people will have a heart attack every year in the United States. So let me give you a little bit of an anatomy lesson so you know what we're talking about. But the heart is about the size of our fist, and it sits right here, right beneath our sternum. It's more close to the front than it is to the back. And I've done an enlarged picture here. I hope you can see that. In my camera, it doesn't show up very well, but I'm hoping you can see that better. If you can maybe let me know if you can see my picture of the heart. So really quickly, again, it's right here. And the neat thing about the heart, it's a muscle, so it contracts, but it also conducts electricity. And so we get an impulse that starts out here, and then it makes its way across the heart. And initially, you get the two atria, which are here and here. These are small, thin-walled chambers that contract first and push the blood into the muscular walled chambers called the ventricles. And then the ventricles push blood to the rest of our body. The right ventricle first goes to the lungs, or it pushes blood to the lungs where it gets oxygenated, and then it comes back to the left side of the heart. And then the left ventricle, really the key ventricle, is what pumps oxygenated blood to our brain and body. And again, 100,000 times a day, it's doing that, and pretty efficient. So the other thing is, how does the heart get its blood flow or supply? How do those muscles get nourished with oxygenated blood? This is the part where the design of the heart makes me scratch my head, because even though the heart is pumping, liters of blood every day, hundreds of liters, its own blood supply is kind of tenuous. We have these coronary arteries, and where they come off of, when the blood comes from the left ventricle, it goes up through this structure here called the aorta. You know, it's a different color here, maybe purple. And so that's going to come up through the aorta, or blue. And right at the atrial valve, we're going to have a few little coronary arteries going to come off the root of the aorta. And again, the aorta is going to deliver blood to the brain, and then it's going to come down and deliver blood to the body. And so we have a right coronary artery that brings blood to the right side of the heart primarily, and also to the back of the heart. And then we have the left main coronary artery that comes off, and then it branches to the right circumflex, and then the long anterior descending that really supplies blood flow to the primary left ventricle. There is a term called the widowmaker, and I misinformed a patient recently because I always thought the widowmaker was plaque formation or heart attack that occurs in this short segment called the left main artery. But in actuality, if you read the text, there's kind of the long anterior descending, which is after that circumflex comes down. This is the LAD. And then here is the left main. I'll abbreviate those. That having a heart attack in either of those is really considered what we call the widowmaker. And what I mean by that is if you have a heart attack that involves these segments, that could be oftentimes fatal. And of the heart attacks that occur, about 25% of heart attacks that occur are fatal. In women, that percentage is actually higher. Women are more likely to die of their first heart attack than men, and we're not quite sure why. Okay, so next is what is the basis? What happens? Why do we get heart attacks? And it's really a lifelong process called atherosclerosis. And for those of you who know the root word athero, if you can type that into the comment box, I'm curious what you think that means. It's close, but it's a Greek word that means gruel, or this thin, watery porridge. But in my understanding, these plaques that form over time are these calcified plaques anyway, are hard plaques. Now, the hard plaques tend to be fairly stable, but where we see hard plaque, we also will see soft plaque. And over time, this plaque buildup, which is in the inner lining of the artery, can restrict blood flow. And also you can get soft plaque that's not stable, and it can rupture. And then it forms a clot within the lumen, or the inner core of the artery, and it cuts off blood flow. So when you lose blood flow to the heart, to a portion of the heart, whether it's part of the ventricle or elsewhere, it's called a heart attack. And it's something that's super common in our society. So what are the risk factors for heart disease? The number one is probably family history and genetics, although they play a small role. There are familial hypercholesterolemia, which is an inherited condition, which puts people at much higher risk for having heart disease, is super important to diagnose. We know that there are families who have a lot of heart disease, and you got to be careful for those people's sons and daughters to make sure you work them up properly. Another risk factor, high risk factor, is smoking. So we know that smoking can cause all sorts of cancers, but it also is a major contributor to heart disease. Another one is high blood pressure. So with high blood pressure, maybe I talk a little bit about that. The medical term is called hypertension. About a third of adults have hypertension. Most don't know it. Those who do know it and are getting treated with medications are not being controlled with the medications they're being treated with. And so that's a big problem. I think a lot of people say, so I have high blood pressure, a big deal, I'll just take a pill. And a lot of people, even my patients, and I try to do the best I can, don't monitor their blood pressure at home. So when we look at blood pressure, ideally, and we have two numbers, we have an upper number and a lower number. The upper number is systolic pressure. So that's when these ventricles are contracting. There's an increased pressure in our arteries. That's called systole, and that's going to be a higher number. Then when the heart is in between beats, it's relaxed, the blood pressure is going to be lower. Ideally, we like to see the top number less than 120 and the bottom number less than 80. And this is measured in millimeters of mercury, which is a pressure. And we check through a blood pressure cuff. And I did a little podcast or snippet on blood pressure monitoring in the past, so you can refer to that. We start to get concerned and put people on blood pressure medicine when the top number goes above 140 or the bottom number goes above 90. And there's been a lot of clinical studies, but we see a really big uptick in stroke and heart disease, mainly coronary artery disease, like we're talking about here, when that top number goes above 140 and the bottom number goes above 90. So another risk factor is high cholesterol. A lot of people focus on cholesterol as being one of the primary generators of plaque formation, and in part that is true. We do know from a lot of clinical studies done in humans, the higher your LDL, which is your low-density lipoprotein, this tends to be the culprit for heart disease, and this gets somewhat complex, but I'm just going to write that down, is LDL. And this stands for low-density lipoprotein. And I kind of think of this as the carrier for cholesterol molecules. And we kind of coin this as the bad cholesterol. But really, its job is to shuttle cholesterol to other parts of the body. However, sometimes if these particle sizes are small, they can cause inflammation or oxidation within the wall of the artery and lead to plaque formation. So we do know that as this plaque builds up in the arteries with heart disease, these coronary arteries start to narrow. And this reduces the flow of blood, and plaques can also rupture, like I spoke about. So one of the things I'm starting to do is look at subfractionation of the LDL. So looking at not only the number of LDL particles, but the size. And it seems like that number of LDL particles is even more significant in terms of your risk for heart disease than just the LDL number you would get on a standard lipid panel. Hey, Martha, thanks for listening. The other one is HDL. So I'm going to write that down. We call this the healthy cholesterol. And I used to tell patients, if you have a really high HDL, you're kind of protected from heart disease. That's no longer the truth. And the reason is because HDL, again, these are kind of carriers of cholesterol that take cholesterol back to the liver to have it metabolized. Again, the main producer of the LDL that we measure is from the liver. And it gets packaged in these apoproteins, primarily apoprotein B. And the reason I remember that B is bad. And these get shuttled around. These carry about 1,500 to 2,000 molecules of cholesterol for each LDL. HDL only has about 45 molecules of cholesterol. So what we're realizing is high HDL, although it's beneficial, is not protective like we once thought it was. So cholesterol is a big issue. If you have a lot of family members with high cholesterol, you have heart disease at an early age, and your LDL is greater than 190, and that's in milligrams per deciliter, your risk of having this condition called familial hypercholesterolemia is pretty high. There are genetic tests we can do. We can look at the LDL receptor mutation. We can look at ApoB, and we can see if maybe you're at risk for having heart disease. Another blood test that we can look at that increases your risk for heart disease is homocysteine. And homocysteine is a molecule that's a methyl donor to methionine, but the buildup of homocysteine could be due to a deficiency in folate or vitamin B12, but it's also an independent marker for heart disease if this goes greater than 10. Another one is uric acid, which I honestly didn't know about this. I usually measure it to see if people are at risk for a condition called gout. So usually if uric acid is greater than 6.5, you're at risk for developing this condition called gout. Gout is a condition where you get a very painful, inflamed joint. And the most common joint is that toe joint. We call it the first metatarsal phalangeal joint. But you get it in your knee, you can get it in your wrist, your elbow, your ankle. So that's gout. But people who are symptomatic for gout have a significantly increased risk of developing coronary artery disease. And we treat that by lowering purines in foods. So certain foods like beer, gravies, shortbreads are very high in purines. We get people to lessen that. And in some cases, we can control that. Also with medications, we can lower that uric acid level. Another blood test that we get is called hsCRP, and that stands for high sensitivity C-reactive protein. And this is also made by the liver in response to inflammation of the arteries. And ideally, we like to see less than 1.0. Average risk is a 1.0 to a 3.0, and high risk is greater than a 3.0. So it just gives us an idea. It's not very specific, but it's something we can monitor. So getting people on an anti-inflammatory diet, omega-3 fatty acids can help. Exercise seems to help lower that high sensitivity C-reactive protein. Again, not as much of a culprit as maybe the LDL is in terms of promoting plaque formation, but it could give us an indication of inflammation in your arteries. And then I kind of mentioned briefly there's a couple genetic tests. One that I'm going to start getting on patients as I'm learning more about it. It's been in the news recently in the medical literature. Is called lipoprotein A, or LP little a. And this is it's a low density lipoprotein like the LDL, but it's a variant, and it contains a protein called apolipoprotein A. It is, in genetic studies, people who have a high LP little a are at higher risk for heart disease. And there isn't much you can do to lower it. In the past, they felt that taking high-dose niacin would bring down the LP little a. Not everybody who has an elevated LP little a are going to be at increased risk. There are some people who are, but some people aren't. I actually have a high LP little a. This is something that just needs to be checked once in a lifetime because it generally doesn't change during adulthood. I have had it checked over the last probably 15 years a couple times, and it's been high both times. I have done coronary calcium, artery calcium scans, and my numbers have been good. So again, I don't think I'm at risk, even though I have an elevated LP little a. So that's some of the blood tests that we look at. Another risk factor for heart disease is being sedentary. So this kind of goes without saying, but the majority of Americans tend to be sedentary. The majority of physicians in the United States tend to be sedentary. But we do know that exercise is medicine, and exercise reduces all-cause mortality, reduces risk for cancer, heart disease, risk for obesity, type 2 diabetes, osteoporosis, stroke, dementia. So benefits of exercise are really broad, and they've been really detailed in the history of the medical literature. So really making exercise part of your day is really important. And that can't be stated strongly enough. But it is hard. Oftentimes we work with health coaches to get people motivated, to get a plan together so that you can if you have a plan, you're more likely to stick to it. But it's not about running marathons. It's not about deadlifting 400 pounds. It's really about the consistency of being able to make it part of your day, doing different things. Really the three facets of fitness are strength, endurance, and flexibility. So trying to incorporate each of those into your weekly routine. So one day you may be doing something that improves your endurance. The next time you're working out, you're doing something that improves your strength. The next time, an activity that improves flexibility, like yoga, for instance. The next thing I want to talk about is a lot of patients will come in and say, hey, my neighbor in the cul-de-sac just had a heart attack. He was only 62. I want to make sure this doesn't happen to me. We're about the same age, or I'm 10 years younger. What do I do? So again, we do, first things we do is blood work, then recommended blood work. I also do an omega check to look at your omega-3 and omega-6 levels. I'll do a diet intake, see what kind of food you're eating, because we do know that your diet is a good predictor of heart disease. If you eat a lot of processed food and maybe high processed meats and a lot of trans fats, fried food, and sugar, it's going to increase your risk for heart disease. And so eating healthy is super important. Lost my train of thought there. But so diet's really important, eating a healthy diet, and a lot to be said about that. I incorporated nutritionist Steve Holmes in our practice to kind of go into details. Oh, I know, when patients come in. I also look at family history. So family history, like I said, is important. If your mom or your dad or a brother or a sister died early, and for a male that's less than 55, or if it's a female relative, mom, sister, before 65, that's a major risk factor. These are people I'm going to take a much deeper dive in really trying to work up their heart disease. And so that's really important. Again, measuring blood pressure. Anybody over 40 should own a blood pressure cuff. And I was going to have one here, but just a simple one that goes over the upper arm, a digital one. Omron makes them, several companies make them. They're inexpensive. Check a few times a week. If it's normal, we talked about that, less than 120, less than 80, check it a couple times a month. If it's greater than that, check it more frequently. Involve your doctor with your readings so you can make adjustments. A lot of times you can start exercising more, lose a little bit of weight, improve your diet, improve your sleep quality, reduce your stress, maybe change your habits that cause your stress. And those all can reduce your blood pressure. Studies looking at meditation back in the late 60s with George Benson out of Harvard showed that you can lower blood pressure to a degree with just regular meditation. So those are the things I look at. Then of course we get blood work. And then there's a variety of things that we can look at to work up heart disease. And most of you have known, like, gosh, should I go get a stress test from the cardiologist? Well, we know that to have a positive stress test, meaning one that shows during exercise your heart's not getting enough oxygen, you almost need a 70 or 80% blockage or narrowing in a coronary artery before you will show up on a stress test. So it can be very misleading and too reassuring if you have a normal stress test. So the recommendation is really only to test those people who are symptomatic, meaning they have chest pain, shortness of breath, chest tightness during exercise or at rest, or people who have multiple risk factors. One of the things I haven't mentioned that I should, so I'm going to interject for a second, is type 2 diabetes or type 1. Both of these increase your risk of heart disease by 100%, or it doubles your risk of heart disease if you have diabetes. So super important. Again, these are all modifiable risks. Stop smoking, exercise more, eat healthy, get plenty of rest, stress reduction techniques like meditation, staying away from sugar, trans fats, excessive alcohol use. These are the things that can lower your risk significantly, and they're free. They don't cost you anything. But there are things that cardiologists will do, and that one is a exercise stress test. Again, I don't think they're necessary. Studies have shown we probably test way more people than we need to, and that gets into the whole economics of medicine, which in this country is so far off, and we do so many unnecessary procedures and prescribe so many unnecessary medications. And by the time, I'm looking at the time now, we won't have time to get into the treatment of heart disease, other than to say these modifiable risk factors is where I start with patients. I don't just start with a prescription for statins, because I don't think that's the way to go. Because studies have shown people who get a statin tend to change their diet for the worse, and they feel they're being protected by this prescription. And instead of really talking about lifestyle, but it's rare that doctors will talk to any of their patients about lifestyle because of the short amount of time they have to spend with patients. Our office is very different. We take the time. We want to know what you're eating. We work with nutritionists and health coaches, so that's kind of part of our practice, and that's how most practices need to go towards. So really a grassroots effort, I think, for everybody to really pay attention to this lecture and try to implement some of these things, because the cost of healthcare is just exploding. What was the study I heard? 8.5 billion prescriptions were written for last year, which is a doubling from 10 years ago. And we are just a pill-popping society, as well as procedures. We order more CT scans, ultrasounds, and MRIs than any other country, and most of them are unnecessary. I've heard up to 70%. 20% of procedures that are done are unnecessary. So I'm not a huge fan of just screening everybody for heart disease with a stress test and say, oh, stress test is normal, you're fine. No, you really got to bring all that information in and not screen people who are at low risk. Moderate and high risk, different story. The stress test can be great. In our office, I'm actually very proud of the fact that we do fitness testing. So fitness testing is very similar to a stress test, but we're really measuring your VO2 max, which is your heart's ability and your lungs' ability to process oxygen intake during exercise. That's very different than just doing a stress test. This is actually looking at your fitness level, which is the single biggest indicator of your health and longevity. And I recommend all my patients get this once a year. And unfortunately, this plea falls on deaf ears because everyone says, well, I'm not in shape, or I can't afford it. Insurance covers it, so that's not an issue. And you want to find out what people's fitness level is, not having them train for a fitness test for 3 to 6 months and then come and get tested. So I do recommend fitness testing to everybody because it gives you a starting point. And then our exercise physiologist can set up a plan for you, especially if you're somebody who doesn't exercise. You want to start an exercise program. A VO2 fitness test is a great beginning point. So that the exercise physiologist, we work with Saul Blau, who's got more experience in this space than anybody. He can design a fitness plan for you, and then we can check you every 3 to 6 months to see if you're improving. Your VO2 max should improve if you're doing exercise. And those with the higher VO2 max, they just live longer. We know that from studies. The people with the lowest VO2 max or poor heart rate recovery after an exercise test is a very strong indicator of underlying heart disease and risk for having a heart attack. So, in summary, the heart's a pretty amazing organ. It does. I just, it's hard to imagine. It beats 100,000 times a day and pumps volumes of blood everywhere. And its blood supply is very tenuous. You get these small coronary arteries that supply blood. And that the standard American diet, the standard way of living in the United States, promotes heart disease. We know that. So we really need to kind of move the needle away from just the standard lifestyle that most Americans lead and change the language that we use. It should be, exercising daily, staying away from processed food, staying away from fast food. Don't buy soda anymore. Don't buy things that come in a bag, box, or wrapper, unless there is some nutritional value in there. Eat nutritionally dense food, and try to get adequate sleep. I use an Oura Ring to monitor my sleep. Some people are using a Whoop or a Fitbit. So these are, the biohacking devices that are out there are going to become more and more. I know Apple's rolling out this whole health promotion with their watch and so forth. Pretty soon we'll be able to probably monitor blood pressure and blood sugar. Who knows, with just a device without having to stick our finger. So we'll see. Time will tell. But I think we really need to jump on this health bandwagon and really encourage each other to live healthy. And right now we just I think we rank 38th in the world in terms of health, looking at things like longevity and rates of cancer and heart disease and type 2 diabetes. We rank 37th, right behind Costa Rica and in front of Bahrain. And I know we can do better. We spend way more on pills and procedures than any other country, and that needs to stop. The average Medicare patient's on 12 prescription medications. That needs to stop. We've got to stop being such a pill-popping society and feeling that the pills is going to save us. A good example is the statins. You take a statin, people think they're saved. They can now eat cheeseburgers and French fries with every meal. And this is the wrong direction we need to be going in. Medical students need to be taught on nutrition, how to educate people on exercise, sleep quality, and so forth. Anyway, I want to thank you for listening. If you have any questions, we've run out of time, you can post them in the comments, and I'll get back to those. Thank you again. Again, Dr. Sunshine, OC Sports and Wellness. Hope you enjoy this. Have a great weekend. We'll talk to you soon.